Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, everybody, and welcome again to AON Podcast. My name is Dhinu Jayaseelan, and today I am joined by Dr. Jake Magel, who's a research assistant professor at the University of Utah in the Department of Physical Therapy and Athletic Training. Dr. Magel has completed his Doctor of Science and Fellowship training at the U.S. Army Baylor University and his PhD at the University of Utah. His research focuses on the management of individuals with musculoskeletal conditions. Today, we'll be talking about his paper, which was published in PTJ back in 2020, titled The Time Between Emergency Department Visit and Initiation of Physical Therapist Intervention, Healthcare Utilization and Costs. Dr. Magel, thanks so much for joining us today.
Thanks for having me. I'm happy to be here.
So this isn't your first paper kind of around this topic. Can you give us some background about why this topic was of interest to you and your research team?
Well, we have looked at the timing of physical therapy after access to primary care provider and the impact on healthcare utilization and costs. And we thought that looking at a similar question in those that access the emergency department was important due to a very high number of patients who actually access care for low back pain in the emergency department. I think it's like it's the third or fourth most common condition in the ED. And so that's really why we thought it was important to do this research.
And for those who haven't read the study or those who've read it maybe a little while ago, can you give us a brief rundown of what your author team did and what you found?
Sure. So it's important to note that this was retrospective work. We used Utah's all payer claims database, which is a database where if an insurance company insures more than 2,500 people, then they are obligated to submit information related to the healthcare claims that they pay to this database. And so it was just people who access the emergency departments in Utah. And what we did is we identified people with low back pain who accessed the emergency department and followed their outcomes over the course of a year. And we categorized patients as having either received early physical therapy or delayed, which was defined as early PT was defined as receiving attending physical therapy within 30 days of the emergency department visit, and delayed PT was attending physical therapy between 31 and 90 days. And then the outcomes that we were interested in were whether or not there was a difference in numbers of people that received advanced imaging, surgery, long-term opioid use, and injections. And we were also interested in their healthcare costs and follow-up ED visits. And what we found was that those individuals that attended physical therapy early were less likely to have lumbar surgery in the year following the emergency department visit. And they were also less likely to have advanced imaging and also less likely to be on long-term opioids. And they incurred lower healthcare costs.
I always am happy to see when the research supports what our intuition is. And in this case, our intuition says that people that get care earlier probably don't need as many resources on the back end. But from my understanding, based on this paper and the data that I saw, it seems like the people that had a harder time getting in early or that maybe used more money in terms of healthcare dollars are the persons that did not have commercial insurance or Medicare and that had more comorbidities. So to me, that speaks to people with fewer resources and more comorbidities, worse general health status. Those are the people that are not being seen as early and actually being seen more frequently to spend more money in healthcare dollars. Is that correct?
I generally agree with that in that if people are under-resourced, they might delay care, and delay care is certainly associated with worse healthcare outcomes, to include increased healthcare utilizations across a variety of healthcare conditions. And so I think that your intuition with respect to this particular paper is also correct.
Yeah, I mean, there's so many variables that can go into that. One being the people that maybe don't have as many resources, can't take as much time off, and things like that. So there's a ton of variables that can't be controlled in this type of study. But besides resources, there's just obviously a disconnect, as there often is, between what happens in the real world and clinical practice and then what happens in the evidence. And your article here and previous articles have suggested that early access will probably lead to better outcomes. So then, if that's the case, what do you think are some factors that are preventing PTs from seeing people with primary acute onset low back pain earlier to maybe reduce their need to be seen later?
That's a great question. And I think one of the first things to point out is that not everybody needs it. Number two, we don't have good, easy clinical pathways making it simple for the patient to actually access physical therapy after an emergency department visit. There are barriers thrown up, like increased like wait lists to get into PT. Maybe even that there is not an easy way for a emergency department physician or provider to actually make a referral. Here at the University of Utah, until recently, there wasn't a actual way for an emergency department physician to refer a patient to physical therapy for low back pain. It couldn't happen. There were barriers put up to that. And so some of it may be structural in that there aren't mechanisms to do it. Other reasons are on the patient side. Patients may not realize that they could potentially benefit from physical therapy. And certainly another reason that people don't access physical therapy early or at all are the costs associated with PT. It's expensive. And that clearly is one reason why people don't access PT at all. In fact, we did a little qualitative work here on looking at patients that made a choice to attend PT or made a choice not to attend PT, and those for back pain. And for those people that chose not to attend, the biggest barrier for them was the cost of physical therapy.
That's such a great point that you bring up, because I think sometimes, myself included, we have a bias that more people, when they get to PT, they'll do better. But there are a number of people that don't need care at all. And healthcare, whether it's PT or otherwise, can be really expensive. So one stat or one data point that I saw in your study, which really drew my attention, was that the mean total 12-month low back pain health-related costs for all patients who didn't attend PT within 90 days of an ED visit was about $800, $788. For those who received early PT, the mean average was about $5,000, and then delayed PT was about $8,700. So delayed PT compared to early PT, you're saving about $3,600. But if you don't need PT, you're saving about $4,000. So I think it's important that we don't interpret this work as more people need to be seen by PT. Is that correct?
I agree with you 100%. As physical therapists, we like to often think that everybody would benefit from our services, and perhaps everybody that needs care would be likely to benefit from our services. And so if a patient chooses to attend PT, what we know from this study is that if they choose to attend PT, early is better than later. But when we look at the total cost for all patients that did not use physical therapy, they are low. And when patients do attend physical therapy, there is a cost associated with that. And some of that is, included in that $4,900 cost for all patients who use physical therapy. But in addition to that, if you go to physical therapy, then you might be a little bit more involved and therefore have other low back pain related costs associated with it too. And some of that is included in that number also. But I agree with you that it's very important that we not over medicalize low back pain and say that everybody needs to go to PT. Rather, we need to be much better at screening people who are appropriate for PT and then get them there quickly if they want to go.
And then when it comes to screening, like you mentioned, there's mechanisms that are in place in some cases, mechanisms that are not in place in some cases for the referral from an ED to a PT, or from primary care to PT. There's wait lists. There's all these things. And like you mentioned in your paper, it's becoming more and more common practice. We have it here at our metropolitan healthcare system at GW in DC. We have PTs in the ED, and they can screen out who maybe needs more musculoskeletal care and maybe refer out quicker. There's the start back tool. What tools do you think? What would you recommend for PTs that are trying to expedite the process of getting people that need care to care quicker?
That is such a good question. I think that if somehow we can institute a tool like the Start Back, I don't know what the tool is, frankly, but a tool like the Start Back into the ED. The problem is that when patients are in acute pain, a lot of them are going to be naturally high on levels of catastrophizing and fear and so on the Start Back screening tool. And so they might be actually identified as people who need physical therapy when maybe they don't, but it's just because of their acute nature. And we don't know actually from the study how many patients truly had an acute episode of back pain. All we could really tell was that it was their first consult for back pain within 6 months, actually. They could have had back pain before and not consulted for it, but they chose to, at this time, to access the ED for their initial consultation. So I don't really know what the best tool is yet, but something that we can use in the emergency department for screening patients that are appropriate for PT. Maybe better yet is to have somebody like a physical therapist in the emergency department setting to talk to people and use psychologically informed management for those people that have a high initial rating of pain and fear and catastrophizing and so on. And I think anecdotally, here at the University of Utah, again, it's just anecdotally, when the patient sees the physical therapist that was embedded within the emergency department here at Utah, they left the department feeling better. And actually, there's some evidence that we published showing that they were less likely to receive an opioid and less likely to receive an image in the ED if they saw the physical therapist first. And it seemed like that they were more likely to attend physical therapy afterwards if the physical therapist communicated to the patient that they thought that would be beneficial for them.
In what you said, you bring up a really important topic, is that there's a perception that the PT and the ED is doing like a musculoskeletal screen and checking to make sure this is low back pain and then maybe providing exercise and then referring out. But also, and potentially even more importantly, it's talking about the natural progression of low back pain and what is pain. And just today, I had someone in the clinic that has back pain, had a flare-up of back pain. She was pain-free before this flare-up, and we talked about how this is just a flare-up, and her pain went from an 8 to a 0 without me even touching her or her exercising, and just knowing what is pain, what's safe, what's unsafe. I think having those conversations, that wasn't necessarily tracked in this study, but I think that would be a really interesting component to track and measure to see how do people do long-term if they just know what pain is.
Yeah, I agree. And I think there's a space for doing that in the ED. And there might even be, it's probably a tall order to say that all emergency departments should have a PT, although we may feel that way. But whether or not that's going to happen right away it probably won't happen right away.
Yeah.
But maybe there's some space for trying to educate emergency department providers about having conversations with patients about their low back pain that provides them with a little bit more of a psychologically informed sort of conversation. I think there could be some interesting work in the future related to that.
And then kind of following up to additional work and kind of insinuations or inferences from this work. This study that you all did, it looked primarily at healthcare costs and then secondary utilization of other interventions, but you didn't necessarily track self-reported function like with an oswestry or something like that. Would it be safe to infer that people that used less money in terms of healthcare dollars usually were people that got better? Or do you think that would be inappropriate to say that?
I think that is something that we can imagine would happen, but that we did not track with this. You're right. And so, what we've recently done in the emergency department is to actually try to collect that very information on patients. And we're currently tracking their functional outcomes at 6 and 12 weeks after they access the emergency department, and also recording their healthcare utilization after they leave the emergency department also. And I think that it just makes sense to say that those people that use less downstream healthcare utilization probably had greater functional abilities, or they improved in function quicker than those people that did not. To me, it makes sense. We don't know that from this study. And so that's why we've initiated a project to look at something similar within our emergency department here at the University of Utah.
That's interesting. And maybe it's a personal preference, but whenever I try to look at these articles, I try not to read too far in between the lines. And so that's one of the topics I wanted to make sure I wasn't inappropriately looking at. But I did want to go back to actually something you said, which was really interesting to me, the patient's perception on PT. And for me, I think maybe it's not that medical professionals and PTs, maybe it's not that we don't know that early access is effective or helpful. And maybe there are pathways to get there. Maybe it's not that people have a wait list, but maybe it's that the patients aren't informed enough to get there or don't want to get there. And this is maybe just picking your own brain from your clinical practice, your own perspective. What do you think are some barriers for the patient themselves, even if they did have access to get healthcare early for their back pain?
Well, other than the cost that we mentioned earlier, I think that patients typically don't think of physical therapy when they think of, I've got an acute episode of back pain. Chiropractors have been much better at marketing their services that way than we have. And so perhaps we have something to learn from chiropractors in at least advertising to the public. Other efforts are, maybe it's not important for a patient whether or not they access, really, if they've got a new episode of back pain and they want something done. I'd like to say go see a physical therapist, but maybe it's not so important whether they see a physical therapist or a chiropractor, frankly, but that they get some help and get it early. Patients are generally not informed about how to manage their care the best. And that's not their fault. That's probably our fault. That's public health's fault for not saying, hey, if you have back pain and you don't feel like you're getting better, then here are your resources that you should seek out. There have been some public health efforts to do just that in I believe it's Australia. And I don't have the research in front of me, but I think that the outcomes were sort of equivocal. I don't want to go into too much of it because, again, I don't have the study in front of me, so I hate to say too much about it. But better public awareness, better awareness on the part of our leadership in the APTA too, and AOMP, frankly, about how PT can help with healthcare if they access physical therapy early for those patients that need it. So better messaging on a part of physical therapy leadership to the public, I think, is really important. I think that we just generally haven't done a very good job at that too. Not only that, but on the physician side, I think that not all physicians understand what physical therapy has to offer patients. And because of tremendous variability in clinical practice, the physicians are not typically aware, or they don't understand what the patient is likely to get if they're going to refer a patient for acute low back pain. And because of that, they might choose to not refer a patient to PT because of the variability that happens within clinical practice. Why can you have one patient with acute low back pain, but they're going to get 5 different types of interventions, and 2 of them might be based on the current best evidence? And so I think that's part of our problem also, is that physical therapy can be viewed as a black box.
Yeah, there's a lot of factors in it. I didn't anticipate having an answer to that, but I think you bring up a lot of good points, is that there's a lot of variability in our practice. And so physicians that we work with are not going to understand consistently what we do. Because of that, maybe the patients don't understand what we do. But I'm also now thinking that part of that's on us, not just in roles of leadership, AOMT, APTA, but just like in my own role as a faculty member, we talk a ton about evaluation and treatment of musculoskeletal disorders, we don't talk a ton about marketing how to get to us and how we should be able to kind of facilitate the business side of things. So that's definitely something maybe we can do better. But this topic was so important to me, and it's so consistent in my daily clinical practice because I see persistent pain all the time. I see chronic pain, tendinopathy, patellofemoral pain, and I see people that come in and their first onset of low back pain, their first response is go to the ED. We work in a big metropolitan city. Their first primary care visit, basically, like you said, is to the ED. And then they come to us after they've been waiting for a long time. They've been to multiple specialists. They've had a lot of imaging. A patient of mine recently had 4-year history after a slip and fall, has tramadol, oxycodone, ketamine, nothing helps. Her oswestry is like 88, so this is something we see all day and something, unfortunately, we see all day. So this is really important that this work is being done. So I appreciate that.
Thank you. I think that what you just mentioned is it goes to providing high value care to the patients and eliminating low value care. And if high value care is getting a patient who needs care to the lowest cost provider who's likely to be able to address that condition, i.e. acute low back pain with spinal manipulation, exercise, patient education, then not sending them first from the emergency department to primary care or the emergency department to physical medicine rehabilitation, where then in order to get routed to physical therapy, that time just gets extended. That is a low value clinical pathway. I think that establishing smooth, streamlined clinical pathways for patients of all types of musculoskeletal conditions to get them to the people that they need the most, whether it be PT or surgery, is critical.
You've had a couple different hats that you've worn. You've been a researcher, educator, a clinician, and so obviously the research and publication of this paper kind of puts your researcher hat on. But thinking now more clinically for our clinicians, if you were to pick up this paper, what's the main take home that you want them to have?
Great question. Specifically related to this paper, if a patient comes from an emergency department, do your best to get them in quickly. Oftentimes, patients will wait on a wait list to get in, or patients are just scheduled out a week or 3 weeks or even longer in some cases, some settings. So having a pathway where patients with certain types of healthcare conditions can get in quickly. For patients with back pain to access the emergency department, the quicker we get them in, the better, I think, is what we can say from this study. And so potentially having a mechanism whereby we identify those people that have come from the emergency department and get them in as quickly as possible. Then we're more able to potentially impact their downstream healthcare utilization and costs.
And then I'm going to also play devil's advocate because as a researcher, one of the first things I always look at, and if they're not explicitly written, I kind of insinuate and look at, is the limitations of a study. And so what do you think the main limitation to this work would be for the person that's picking this paper up and trying to apply it to the clinic?
Yeah, great. Number one question is number one thing is that this is not prospective work. It's looking at care that already occurred, and we can never be certain about causality with this type of observational study design. We didn't have information on things like pain catastrophizing, the patient's functional status, which could certainly influence the healthcare that they received, and might be very important covariates to include in an analysis like we did here. But those were just not available, just certainly based on the nature of the data, the claims data.
And for everything that this paper is not, this is still a really important study. And I really appreciate you and your authors putting the effort in, because I know it's a lot of work to get all this data and then synthesize it and then write it up and publish it. So I really appreciate that. For our listeners that are kind of interested in this area, this topic, can you kind of speak to some other projects that you have in the pipeline that you might be maybe putting forward in the short term or near term?
So I mentioned the data that we're currently collecting in the emergency department. And so that is going to serve as some initial pilot data, hopefully to get funding to follow patients a little bit more long term in patients that access the emergency department for different musculoskeletal conditions, and try to learn from those patients why they don't go to physical therapy, because some of them are going to go and some of them are not. So, what is it about this particular patient that's made them choose to access physical therapy or not after the emergency department? What are their clinical factors? What are their patient factors? And interview them with some qualitative work and try to find out qualitatively why they don't go to PT after the emergency department visit.
Yeah, that would be really interesting to find out, because numbers don't tell a story. And so having them tell their own story would be really beneficial to understand.
Agreed.
So that would be great. And so I'm looking forward to that. For those that are interested in kind of getting a little bit more in depth, or maybe even reaching out to you, we always attach the show notes with contact info. Is it all right if they go ahead and email you or kind of get in touch with you if they have any follow-ups?
Of course. Yep. Please do.
Yeah. So Dr. Magel, I appreciate your time. Thank you so much for joining us. Really do appreciate you putting this work together and then spending the time to talk about it.
My pleasure. Thanks for having me.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.